Hello and welcome to It's Your Case, presented by VetCT.com. I'm Lucy Meehan, I'm your radiologist on demand for this week. Today's example is a 12-year-old thoroughbred gelding with an acute onset grade 3 out of 5 right forelimb lameness. Once you've reviewed the radiographs using your systematic approach, then you're ready to watch this video. So I'm going to start by showing you the lateromedial and the dorsoplantar view, and I think we can all see on the lateromedial view we've got a large, mildly dorsally displaced osseous fragment with a transverse radiolucent line transecting this from dorsal to plantar, which represents our extensor process. So what we've got is a fracture through our extensor process, and then we've got a mildly dorsally displaced fragment. If we look at our fracture line is fairly well demarcated. The edges of the fragment are fairly sharp, which indicates it's probably an acute problem rather than a chronic problem. If we look at our articular margin, this is the articular margin here, and then we've got a step and a gap in the articular margin. So we've got the proximal, so dorsal third of the articular margin is attached to the extensor process fragment. Then we've got a gap of a few millimetres, and then we've got the distal or palmar portion of the articular margin attached to the remnant of the distal phalanx. So if we look on the dorsoplantar view, we can see that we've got a small a narrow radiolucent line, which isn't quite as well defined as on the lateromedial view, but that traverses in a proximomedial to distal lateral direction, but it seems to go all the way through the distal phalanx. And you can see that it's maybe slightly laterally displaced just here, the extensor process fragment. We've also got a slight soft tissue swelling, just dorsal, just proximal to the coring band on the dorsal margin. This probably represents some mild effusion of the distal interphalangeal joint, and certainly that is somewhere to look. And it's really important when we're looking at radiographs, especially the feet, that we don't neglect our soft tissues. If we come down and assess the rest of the radiograph, we've got a very small osteophyte just here on the dorsodistal aspect of the middle phalanx. That's probably chronic and probably unrelated to the current pathology. However, we have got an interruption in the articular margin, so we do have to be cognizant that there is probably going to be an arthritic issue in the future. Just looking at the rest of the radiograph, well, we've got a slight lipping or a slight osseous projection at the dorsodistal aspect of the distal phalanx, and that to me would ring some alarm bells. So this is a change we often see in chronic laminitis. So if we now look at this horse in terms of whether or not we can see any laminitis, well, actually we've got parallel dorsal hoof wall and dorsal border of distal phalanx, so I'm not too worried about laminitis, but that just concerns me, which is where our dorsoproximal palmar distal oblique view comes in. So I'm going to put this up on the right of the screen, and if we zoom in on that, on the distal solar margin of the distal phalanx, you can see we've got a fairly sharply demarcated radiolucent line with some osseous fragments just distal to that. And so we've got another fracture, a different type of fracture of the distal phalanx. So in summary, we've got a large extensor process fracture of the distal phalanx, so this would be classed as a type 4 fracture. I've popped a reference in the report to tell you what the fracture types are. And we've also got these small fragments here which correspond with this lipping on the dorsodistal aspect of the solar margin of the distal phalanx, and that to me would also be consistent with a traumatic event. I think these are quite acute because our fracture lines are quite sharply demarcated. We've got a suspicion of some effusion of the distal interphalangeal joint, and also in the report you'll notice that we've commented that the solar border of the distal phalanx is flat as well, which may be something that needs to be addressed in the future. Be sure to review the full report associated with this case, and certainly I've popped some further reading on there which you may find useful. Thank you for listening. Remember, it's your case, so please feel free to post questions on social media that we'll do our best to get back to you as soon as we can. Thank you.